A very good morning to all of you present here, respected chairpersons. That's okay, ma'am. Please give me that mic. I really thank the Kanchipuram OBG Society for this opportunity of being here, and we've been enjoying ourselves since yesterday. Topic I have got is fetal biometry, where to freeze. It took me some time to understand that what is it that we are freezing, isn't it? Is it the image, or sometimes even the doctor freezes after the biometry results? So let's start with the image per se. And why we talk about freezing? Because ultrasound nowadays is a real-time assessment. And we keep on looking at things and we suddenly decide that this is the picture I want to take and that is where we want to freeze. So I think we just want to know where exactly we must stop to take a measurement. So biometry is measuring things which have life. Bios is for life and measurement is the metros. So the purpose of doing measurement in ultrasound is to assess gestational age and the growth pattern as such. So why is this very important? It might sound like a very mundane thing, in the age when we are moving, we talked of artificial intelligence, we talked of so many things, suddenly we are deciding where to freeze. That's because the measurement that you take is ultimately going to affect your obstetric decisions. The same decision of whether or not you are going to induce that labor. You see how much technology you are using to make a labor successful, but if you have induced it at the wrong time, the outcome might not be good. So when to make obstetric decisions to avoid inadvertent prematurity, evaluate growth in a good manner so that you are not missing out growth restriction, or even bigger babies for that matter. Interpretation of the biochemical screening test. Just yesterday we had this discussion in our fetal medicine workshop that using a BPD every time to change the gestational age can change your serum screening reports. So biometry has implications on major obstetric decisions and major fetal interpretations. Scheduling invasive diagnostic tests. There are certain tests you do not do at certain gestations, and that gestational assessment again comes by your biometry. And then the option of termination of pregnancy. All of you know that many decisions are dependent on gestational age, and measurement is the most vital way of getting to the accurate gestational age. So this is Galileo Galilei, one of the most thought-provoking individuals of the last few centuries, who said that measure whatever is measurable and make measurable what is not so. Because the only way you can compare two things is if you have an objective method of comparison. And a numerical comparison solves all your problems. Otherwise, this is good, this is not good. It's like your Kanchi saris, isn't it? Since yesterday we are trying to assess which is the best sari of these, but you don't know till you have a numerical method of differentiating the two of them. So let's start with the first important measurement that an obstetrician does, and that is the crown rump length. And again, those of you who were there yesterday in the fetal medicine discussion must remember that it's not the 6 weeks, it's not the 20 weeks. It's the 8 to 13 weeks period which will be the most accurate time for you to define gestation. Because at 6 weeks the fetus is too small and you may sometimes take an end-on measurement or some way that you may not be accurate. But between 8 and 13 weeks, it's very unlikely that you will not take a correct measurement. Why not beyond 13 weeks? Because the fetus becomes a bit vertical and it's difficult to get a good crown rump length at that point. So when you take a crown rump length, what is important? You exclude the yolk sac and you exclude the limbs. Now you see the picture here, you've got a yolk sac there by the side. Sometimes the yolk sac is adjacent to the fetus and you measure all through including the yolk sac. A few millimeters error at this point will change your gestational age and will change the way you evaluate all the biometry later. So the CRL or the crown rump length is a very, very important measurement, and just to bring you the historical perspective, this is a picture of Hugh Robinson. If all of you remember your scan machines, when you put your CRL, it says Robinson's formula. And Robinson's formula was given in 1975. And till date, that is the formula we use for the crown rump length to assess gestational age. Just nothing else has been able to surpass it, because it was such a nice concept that he gave, and that is exactly what we read, ontogeny recapitulates phylogeny. Our embryological development is similar to our evolutionary development. And every fetus at 6 weeks measures similar. Later on it might become macrosomic. All of us here are of different body mass index. But then when we were 6 weeks of gestation, we all started at the same point. It was just a matter of our individual abilities that we reached where we are. So that crown rump length is of utmost importance, and we must know the right way of doing it. The fetus has to be in a longitudinal position, not flexed, not extended. The crown should be clearly seen, the rump should be clearly seen, and a straight measurement across the longitudinal diameter will determine what is the CRL at that point. So the greatest embryonic length should be measured placing the calipers at the head and the rump of the fetus. So at 8 weeks you see a definable head end and the rump end. You see limb buds, you see subtle movements, you exclude all of that and take a crown rump measurement. Of course, measuring the heartbeat is important, and why I am bringing this issue of the heartbeat in the middle of the CRL, because gestational age is one aspect. The first and foremost determination is viability. And the biggest confusion comes when you don't see a heartbeat but you see some kind of fetal pole. And you don't know whether this is viable, non-viable, whether should I wait or whether should I declare that this is a non-viable pregnancy. And that is where you must remember the timeline of development. You start with just a gestational sac, gradually you see a yolk sac, and then you see a fetal pole. And then you see cardiac activity. So when you see fetal pole and no cardiac activity, where are you in this timeline? If you go by the lady's recollection of her last menstrual period, is that accurate? Not always. So you need some foolproof method that you don't make a mistake in your clinical management. And that is what is given in this guidelines for determination of viability. So straight and simple, if the CRL measured correctly is more than 7 millimeter, you must see a cardiac activity. So if you see a CRL more than 7 millimeter measured correctly and no cardiac activity, you can declare that this is a missed miscarriage. If the CRL is less than 7 millimeter and you don't see a cardiac activity, you can wait for 1 more week. If it is actually missed miscarriage, even after 1 week it will be less than 7 millimeter, but you would have objective evidence of 2 assessments 1 week apart where there has been no growth of the size of the fetus and no advent of viability. And then again your decision of non-viability is correct. But suppose you see a fetus of 6 millimeter with no cardiac activity and you just declare that this is a missed miscarriage. It may be wrong, because she might wait for 1 week and then find a heartbeat and then go and say, oh, I went to that doctor and she said it was a missed miscarriage. So your measurement of CRL will stand you in good stead, because there are clear guidelines today as to when should we call it viable and when should we wait for the possibility of viability. In the first trimester screening, the CRL measurement is of utmost importance because nuchal translucency is a function of CRL. So if you don't measure your CRL correctly, whatever NT you've measured will not accurately reflect the risk of Down syndrome. So the NHS gives clear-cut guidelines for the CRL. The picture that I have taken here is from the screening program website of the NHS. It is freely downloadable, and it only states what we have stated so far, that a longitudinal section of the fetus in neutral position with the crown and the rump seen properly has to be used to measure the crown rump length. The measurement of the NT again happens in a head and neck section of the same fetus, where you see the most wide point in the area of the neck of the baby, and that is also an important thing, although it doesn't come in classical biometry, but there also you should know where to freeze. Suppose you have more than 1 babies, what about the CRLs? Now you know accurately to measure CRL. If you have 3 fetuses and one of them has CRL of 7 mm, one of them has 5 mm and one of them has 4 mm, how do you date the pregnancy? You can't date it as 3 different EDDs. That should not be done. Sometimes it is done. We get reports of twin 1 and twin 2 separately with 2 different EDDs. That cannot be possible. You can't deliver one baby on one day and another. So you have to have a combined EDD for the pregnancy. So how do we determine? If there are 2 different CRLs, you take the largest as the indicator for gestational age. There are some studies going on about considering the average but not the smallest. The average is still under trial, so for the time being it's the largest CRL which we use to date the pregnancy. If it is twins, triplets, quintuplets, whatever, the largest CRL. So whenever there is a disparity in assigning EDD, if the CRL and the LMP are not matching and the difference is such that it is creating more than 7 days difference, then you take the CRL and date the pregnancy. If the difference is less than 7 days, you stick to the LMP and remember this fact. Then comes the biometry of the bigger baby. So when the babies start having a shape to themselves, we start measuring from head to toe. And head measurement is a very, very important measurement, because if the head is small, what are we worried about? We start worrying about microcephaly and things like that. So they have very strong implications, and therefore our measurements must be in the correct plane. But much before that, the gestational age must be correctly assigned, because if you have not assigned gestational age correctly, you will interpret biometry differently. So for the assignment of the head circumference, what we take is either the transventricular plane or the transthalamic plane. So you have a kind of oval outline of the fetal skull, you have a cavum septum pellucidum, you have a midline fox, and you can see the posterior horn of the lateral ventricle. There you place your calipers out to out. So where you see the head, the bony shadows, you place it out to out. There is a debate whether out to out or out to in. Earlier books used to say out to in, but those were the times when the machines were not very good and the distal resolution was not great. So you would not be able to see the outer border of the distal shadow. Whereas now we get very good resolution at all levels of the screen, and out to out is more physiological, because when the child is born, how do you measure head circumference? Out to out. So out to out always corresponds more to what you will do postnatally, and that is how you do. Now when you calculate head circumference, you need biparietal diameter as well as the occipitofrontal diameter. You can either do it as a composite measurement with this formula, or you can take a ellipse of a head circumference, whatever you wish to do. But remember that there are normal variations to head shape. So if the head is brachycephalic, you might have a smaller occipitofrontal diameter and a larger biparietal diameter. If it is dolichocephalic, longish head like that, you might have a longer occipitofrontal and a smaller biparietal. So don't get thrown away. Like I said, don't get frozen yourself if you see something different in the measurements, because this is what is called cephalic index, and there is a normal variation to that. If the overall head circumference is not falling within the correct centiles despite correct gestation, then you start freezing. So the accuracy of the biparietal diameter is about plus minus 11 days in the second trimester and plus minus 21 days in the third trimester. Do you think it's a good method to date a pregnancy? 3 weeks disparity. So in the second and third trimester, whatever you try and do, your methods will be suboptimal. Why do we date by head circumference? Because we assume that the compromise in the head circumference will be less than anything else. Body will try to preserve the brain even if it is insulted in terms of growth resources. So the head circumference can be used for dating in the second trimester with an inaccuracy of 11 days, but it's always better to date by early pregnancy CRL. So these are the standard views. The other view in the head is the transcerebellar diameter. Normally we don't use the cerebellum as a method of dating, but we can use it to corroborate dating if you are you have not had an early scan and now the baby comes and then you are confused. Then the transcerebellar diameter corresponds to the gestational age till about 20-25 weeks, and thereafter it's slightly more than the gestational age. So it can be used to corroborate your gestational dating. So up to 16 to 24 weeks it corresponds to the gestational age. However, we don't use this as a dating method because there are pathologies where only the cerebellum might be small, and these are genetic conditions like pontocerebellar hypoplasia, so we don't use that as the primary dating method. Orbital diameters are measured in a way that the interorbital distance should be such that it can accommodate just one orbit. If there are vagaries here, you are worried about abnormal facies.
Abdomen circumference, very important measurement. It is measured at the level of the upper abdomen, where you see the stomach and the umbilical vein like a hockey stick going away from the stomach. If you are at this level, you are measuring maximum of the liver diameter. And what is the liver? The liver is where the food is stored for the fetus. So if the abdominal circumference is very less, then that means the baby is not growing very well. Femur length, it should be measured along the longest diaphysis, excluding the epiphysis. You should freeze at a level where the epiphysis is not included. Same with the humerus. Whenever you see short long bones, always compare the gestational age and also look at the parents. If the parents are short, this may be a physiological type of shortening of the long bones. Whenever you do biometry, plot them on a chart and look at the pattern of growth rather than just what the growth is today, because growth is a continuous phenomenon. And if you don't date it correctly, like you see here, all the parameters are less than gestational age, but the problem is she forgot her dates and it was 4 weeks away. So if it's 23 weeks, it's correct gestation, correct biometry. If it's 19 weeks, it was all looking like growth restriction. So this is how you look at the trend of growth. This is normal growth and this is where the growth is tapering. So whenever things are falling off the charts, that is where you will start worrying, because that is where you will pick up that group which is at risk of problems like unexplained stillbirths and neonatal problems. So this is where I would just like to stop because I am running out of time. But my whole message to you is, do not look at biometry as just an exercise of measurement. It is an exercise of interpretation after you have fixed the gestational age, and then you interpret whether or not the growth is in the correct parameter. If it is not, then you try and you re-look at the baby, because measurement is your first step towards taking clinical decisions. So if you have to take those decisions, take them correctly. Do not make any mistakes, because the first principle of medicine is do no harm. Thank you very much for the patience.
Thank you.